Good afternoon. I'm MJ Decoto, and I'm the Executive Director of Rethink Breast Cancer. And thank you so much for coming out on such a beautiful afternoon and seeing this film and staying for our talk. That was obviously a very provocative film, and I think we have a lot to digest. And I'm just so thrilled that we have two wonderful experts here to help us understand some of the issues raised in the film. So I'd like to just introduce them. We have Dr. Archie Blair, who is a clinical research professor at Oregon Health and Science University. He did his undergrad at MIT in Boston and his med degree at University of Rochester. He is actually extremely accomplished in pediatric and young adult oncology. He was the founding director of one of the young adult cancer research organizations in the United States. For 10 years, earlier in his career, he chaired the Children's Cancer Group at the world's largest pediatric cancer research organization at the University of Texas MD Anderson Cancer Center. His interest in screening mammography began as an American Cancer Society professor of clinical oncology at the University of Washington. He's the co-author of a study called Effects of 3 Decades of Screening Mammography on Breast Cancer Incidence, which was published in the New England Journal of Medicine in November 2012. He's been awarded numerous research grants as principal investigator, and his research has been published in more than 300 peer-reviewed articles, chapters, and books. That's it. Let's welcome Dr. Blair. Also very pleased that we have Dr. Frances Wright with us. Her bio is slightly shorter, but she is younger. Dr. Wright is currently an associate professor at the University of Toronto and practices in surgical oncology at Sunnybrook Health Sciences Centre. Her clinical areas of research are melanoma and breast cancer. She is now the program director of the University of Toronto General Surgery Oncology Fellowship Program. She has a personal interest and a career interest in multidisciplinary cancer conferences and has done some research on the barriers to their initiation and is currently a consultant for Cancer Care Ontario on this topic. Dr. Wright has already garnered prestigious awards for her research. We've invited her here today because of the research she is doing in breast cancer. Part of her research is looking at why women with early breast cancer are choosing mastectomy. So we've been looking forward to this conversation for months and months that we've been putting together this panel. Mammography has been in the headlines for, well, forever practically, but definitely in the past 4 years. It's been debated in the media quite a bit, and much of that has been instigated by the United States and Canada having governments organize special task force to really look at mammography screening and make some new recommendations. So those were published in the United States about 4 years ago and in Canada a couple of years ago. And basically, the task force recommendations were finding that there were some modest benefits for mammography for women over 50. Rethink was very interested to hear that these task forces were saying there's really very little benefit for women under 50, which is the population we serve. But the recommendation was that women really talk to their doctors about their own personal risk profile and really try to identify if they should be screened earlier, if they are in a high-risk category. And it seemed to be this shift from one-size-fits-all screening program to one that was more personalized, which has been a buzzword in medicine. We're hearing about personalized medicine. Now, the guidelines, which seem to be aligned with the UK and Europe, caused an absolute uproar in both the United States and in Canada. I've been to talks where they've been debated at San Antonio Breast Cancer Symposium, very heated arguments with academics arguing each side. Radiologists seem really angry at epidemiologists, and we have survivors upset, survivors who feel that absolutely a mammogram saved their lives, and I think the public is really confused. So I'd like to start with Dr. Blair, and just maybe you can tell us, first of all, who are these task forces that came up with the recommendations, and what led them to make these recommendations?
Who are these task forces? Well, I actually know one, and that is the major one, the one that was formed in 1957 in the United States. There may be other task forces. The UK has its own review panel. That may be one you're also addressing or would like to discuss, MJ. The U.S. Preventive Services Task Force is actually multiple task forces. There's one for several different diseases, and breast cancer has its own task force. It is made up of 17 experts, MDs, MD PhDs, Masters of Science, epidemiologists, biostatisticians, and biologists. They were all selected very carefully for not having a prejudged opinion or a conflict of interest. They were as independent and as neutral as it's possible, and that always is a difficult matter. I'm very impressed by that group. They also, in turn, relied on others. They had two other panels, one that was made up of biostatisticians and epidemiologists to look at 6 different models of estimating what would be the safest thing to do for breast cancer screening. And then they had yet another panel, which I happen to have some knowledge of because it's somebody I work with in the faculty at Oregon Health and Science University. And that panel was also made up of experts, and they looked at the bigger picture in terms of health services need. So I don't know how one could form a more neutral, independent, unbiased set of experts. They, in 2009, 4 years ago, decided that the United States should do less screening. Instead of doing it every year, routinely, from the age of 40 until the woman was not healthy enough to go in for a mammogram. So that was at least 40, and based on the average age of that earliest or oldest age, it would probably be 44 mammograms over the lifespan of that woman, to reducing it to just 13 mammograms. Big difference, 44 or 40 anyway, down to 13, starting at 50 instead of 40, and doing it every other year until 75. So 13 mammograms over those every other years from 50 to 75. But let me quickly add, they didn't say that mammograms shouldn't be done between 40 and 50 or over the age of 75, but that should be a matter of personal judgment between the woman and her physician or physicians, and that there are instances in which that would be a good thing to do. But that should be personalized, as MJ's just pointed out. So I think that describes not only the quality of, even though they've been criticized for not having experts or not having knowledge and thoroughness and being clinicians. One of them is a breast cancer surgeon. And yet they're continuously criticized for not having the expertise to make these judgments. I would say that no matter who is selected, that would probably have been a criticism.
Interesting. So there have been criticisms of the recommendations, and I'm just curious, I mean, your study came out basically at the exact same time that the Canadian recommendations were released. I'm curious, maybe you can talk a bit about your study. Was there resistance to some of your findings, and maybe why do you think there's been such resistance in the scientific community to some of the recommendations for less screening?
In almost 50 years of doing research, clinical research, I have never been attacked the way I was, along with my co-author, Dr. Gilbert Welch from Dartmouth. I'd never seen such a personal attack. Fraudulent, unscientific, unsupported, egregious, dangerous, wishful thinking, had to be retracted. I can't believe that they're making this point. How could it be accepted by a New England Journal? I was totally floored by the criticism, but it came from one community almost entirely, and that was the radiologists who were doing mammography.
Interesting, thank you. And do you have thoughts on why you think, like we have seen the survivor community being quite upset with this information and some people in the public?
Yes, MJ. If I were a woman and a mammogram found my cancer, and I was 10 years, 15, 20 years after that happened, I would believe that that mammogram saved my life. Amy Robach, somebody fairly, potentially at least in the U.S., known well throughout the community, said that in front of 5 million women watching, or 5 million people, I guess, watching that show on TV. And I understand that. But actually, the best data we have is that 1 in 23, somewhere between 20 and 25 women were actually saved as a result of having that mammogram when it found the diagnosis later of cancer. The other 22 still believe it saved their life. But if you step back and look at the entire possibility, it didn't. It was the therapy that was given, whether it was then or later, if it hadn't been screened and detected, but picked up later when it was found as a lump or other symptom and diagnosed then, it too was highly curable and would have saved that woman's life. And 10 to 20 years later, the problem being, I don't know if I'm one of the 23 whose life was saved, or one of the 22 of the 23, and who the therapy would have saved my life regardless of when I was diagnosed with cancer. But the emotion is so strong, and this is an incredibly emotional topic. It's the third rail. You know what I mean?
Advocates of screening programs talk a lot about increased survival times. Now, does that mean women are gaining additional years of life, or are they just living longer with their disease?
You want me to answer? Okay.
Yes.
Probably the single best answer is something you heard in the movie, the documentary, which was referred to very briefly as lead time bias. Okay, let's say, and you heard how long it took, 8 years to double 32 times to become detected on a mammogram. Let's say it was picked up 8 years before. That woman already has at least 8 more years before it would have been detected. And so lives with the diagnosis of breast cancer for 8 more years than she would have otherwise. And those lead times in mammography are at least that long. And some of them are even 10, 15, 20 years, because in the person who has a cancer that will progress and become cancer, real cancer, it takes years and years and years. So those are all additional years of living with the diagnosis and of the trauma, psychological stress, quality of life issues, the fear of it of coming back. When in fact, if they had waited until it was diagnosed clinically, and I'm not suggesting that be done, that's a matter of personalization, but waiting, like the woman with the thermography who's trying to use that to help her decide when to have her mastectomy, and waiting, those years are saved in terms of not having to live with the disease. And the likelihood of having a shorter life is very small. We can probably get to that later.
Thank you so much. Dr. Wright, I'm curious, they talk a lot in the film about overdiagnosis, and how do you define overdiagnosis?
I think overdiagnosis is the diagnosis of a problem or an entity that may have never caused problems for that patient in the future. So perhaps one of the better examples of that within the breast cancer world is if you have maybe an 80-year-old lady who's having mammograms and she gets diagnosed with something called DCIS, which we heard a lot about during the movie. And as we know, that's not a cancer. Sometimes, and we don't actually know the exact percentage of times, it will turn into a cancer. But if we identify something like a low-grade DCIS in an 80-year-old lady, that is probably overdiagnosis, because that low-grade or non-aggressive form of DCIS would probably have never caused that 80-year-old any sort of clinical problems or affected her lifespan.
Dr. Wright, is that different than a false diagnosis of breast cancer?
Well, DCIS isn't breast cancer. I'm not sure it's true. It's still an entity. It's not a false positive, but it's not a breast cancer.
It was just interesting in the film when they were talking about the number of women that are diagnosed. You know, they said things like going through unnecessary surgeries, radiation, chemo. It sounds like a false diagnosis. Why did they have that treatment if?
So this is a very good point, and they also addressed it in the movie as well. We don't actually know what percentage of DCIS progresses into a breast cancer, and there is going to be a study coming out of the UK where they look at women with low-grade DCIS, and they do a biopsy on these women, and then they follow them through time with mammogram and clinical exam, and you find out over time in what percentage of women the DCIS becomes clinically a breast cancer or radiologically a breast cancer.
I'm just curious even about the concept of overdiagnosis in a broader sense. There seems to have been a shift in medicine the last few decades from treating the sick and the symptomatic to maybe this concern about the worried well, and technology is advancing so much that we can see things so much earlier. I know your colleague, Dr. Welch, talks a lot about this in the broader sense. Are we sort of shifting how we define abnormalities as we recognize more people as having abnormalities? Like, what's the net effect of that on our society and on our healthcare system?
That's a broad question, but try to answer it as simply as I can. I'd probably say it's marvelous to see the tremendous revolution in the precision and accuracy of the new technologies to find so small a spot that it may be something you have to do something about. But with that comes, naturally, as I think you're alluding, the ability of finding so many other things that you've had all your life, but now for the first time is detected and makes us wonder, what is that? So the latest terminology to get away from this idea of cancer or pre-cancer, which prejudges that that person actually has cancer, is something that Laura Esserman and Ian Thompson in the States have recommended, was published last year. It's called, and I'll just give you the 4 letters first, IDLE, or indolent, low grade, static, not moving, indolent. Indolent, that's where the IDL comes, and then lesion of epithelial origin. And epithelial means the tissue from which it comes from, and that's what breast cancer actually comes from. But it doesn't say anything more than it's indolent. Another word you may have heard is incidentalloma, instead of a sarcoma or a oma, which infers a cancer, incidentalloma. We're finding those on these new, more sensitive tests like MRIs. My wife went through that, having had multiple incidentallomas the first time she had a body scan of that type. So because we have the ability to look closer and closer and find some more things, we're finding stuff that we don't understand that probably doesn't need our attention, and yet it's there and we have to deal with it. That's the conundrum.
And at the same time as we're finding all these things earlier, are we seeing a reduction in the incidence of advanced breast cancer? I don't know if either of you can answer that. Or
I think your study answers that, Archie.
Okay, I'm going to look out there and ask, how many of you are less than 40? Okay, between 40 and 50. And over 50, I know there are a few. Okay, did Annie put up her hand, by the way? I don't think she did. Yeah. All right, she's our youngest. There she is, okay. There is some evidence from the United States data which needs to be confirmed, and we're hoping that actually Ontario is looking into this for us, because the first time it's reported is just the first time. It needs to be confirmed. But there is certainly a strong suggestion in the United States that the incidence of bad breast cancer, meaning it's already spread beyond the breast and has already metastasized, not just near the breast, but to distant places in the body like the bone or even the brain, is increasing under 50 years of age in the United States. That is our study, but somebody else, and I hope can help us out here to determine whether it's really the pattern or due to some artifact, something that we didn't call bad breast cancer before, because now we can find it with MR scans and these newer tests. But it's increasing, whereas the other forms of cancer, of breast cancer that are not metastatic, that are confined to the breast, are early stage, haven't gone anywhere, haven't left the breast, it's been very stable. That's the good news. But something is happening before the age of 50, at least south of the border, that may be a problem.
so many issues to tackle in this field. It's just overwhelming.
And too long an answers too. Yeah,
That's right.
Sorry.
Yes, we're trying to cover a lot. Just want to go back to DCIS. And Dr. Wright, maybe you could tell us a bit about the research you're doing to try to address this problem of DCIS. Is it on the rise? We're hearing it is by 30%, but you hear so many different percentages. Maybe give us your perspective.
So I think there is fairly clear evidence that since screening programs increased, the incidence of breast cancer has increased. DCIS tends to get lumped in with invasive breast cancer when they're looking at incidence. And overall, the incidence of breast cancer went from about 1 in 12 women to about 1 in 8 or 9 when we started large national screening programs. And the majority of those new diagnoses were DCIS, which is, again, as I mentioned in the movie, it's more of a radiologic finding rather than an actual clinical finding.
Can I add to that? The idea that it used to be 1 in 12 and now is as much as 1 in 8. You hear that certainly from organizations like the American Cancer Society. Big banners about 1 in 8, 1 in 8. 1 in 8 of you have to worry about it. Well, it used to be 1 in 12. What is it? Maybe under the age of 40, it may be more common, although only for metastatic disease. Well, the answer to what's changed more than anything else is DCIS. And if, as we know in the United States, from the best data that we can amount, that 1 in every 3 women, that's 31% is the best estimate. That's what the publication in the New England Journal is about. If 1 in every 3 women have an overdiagnosis of cancer that really isn't cancer, that alone can explain why it goes from 1 in 12 to 1 in 8, because we're picking up 1/3 of the 12, that makes it 1 in 8, who actually don't have cancer and should be warned that that's a possibility when they're diagnosed. And most of it is DCIS, although not all. Some of it actually is localized invasive cancer. So it's not as clear as it could be. But this idea it's 1 in 8 when it's really only 1 in 11 still of the cancer that could be a problem.
And I'd like to comment on that as well. The trouble with DCIS is we don't know whose DCIS is going to turn into a cancer. So it's a significant limit for us as clinicians. So as a surgeon, when a woman comes to me with a diagnosis of DCIS, when I talk to her, I'm like, well, this might turn into breast cancer over years. And, depending on if it's low grade or if it's high grade, that may range from anywhere from 20% maybe to 30 or 40%. But I don't know which woman's DCIS is going to change into cancer. So you can imagine on an individual patient's, in their situation, I've got a lesion that could turn into cancer if I leave it for a number of years. And you can understand why women make the decision to have surgery and other treatments, because they don't know what's going to happen to them on an individual basis. And neither do we as clinicians. So that's why if we're going to look into just following women clinically with or radiologically with DCIS, then we need to do it in a controlled fashion so that it's done in a safe way for our patients.
We got to get to the questions for sure, but I'm going to add one more point to this also. The good news is, especially for those of you who are less than 40, which is most of you, and even those of you who are between 40 and 50 and wonder what you're going to do at 50 when you're supposed to get a mammogram, is that by then we should know, not just on what you heard from those in the film, but from many other studies that are going on in terms of looking at the DNA or the genome from DCIS, looking at what markers predict for a bad outcome. What really is cancer? What is it? We should know that within 5 to 10 years. And you should be reassured that there's going to be good news about this in the near future.
That would be wonderful. I'm just going to have about 5 more minutes of questions, and we're going to turn it over to the audience. One thing that's challenging for Rethink Breast Cancer is we have a lot of young women with breast cancer in our support programs, and different types of cancers. Many have had aggressive, whether it's HER2 positive or triple negative, and different women, different stories, but one of the common themes is the difficulty they had getting diagnosed. So they went to their GP reporting a problem, they were told they were too young for breast cancer, we're just gonna watch and wait and see what happens. Then they end up finally getting diagnosed, and it's very aggressive, and they're thrown into very aggressive treatment. So if one of the ideas for handling DCIS is this watch and wait approach, organizations like us are telling average young women out there, well, if you feel your concerns dismissed, don't be afraid to advocate for yourself for further testing, and almost like a beware the watch and wait. So it's a tricky situation. I don't know, Dr. Wright, do you have thoughts?
DCIS, 90% of the time, there are no clinical findings, maybe even 95% of the time. About maybe 5 to 10% of the time with DCIS will there be a palpable mass associated with it. So it's really the vast majority of times, DCIS is a radiologic finding only. I do think for the women under 50, if they develop a mass, then they should have an ultrasound and a mammogram. It's as straightforward as that.
I want to get into some of what we would consider at Rethink, some of the more controversial issues raised in.
Not that none of what you've asked was.
Oh, really? When I first saw the film, I was very alarmed at the talk about radiation and x-rays. I myself am in a high-risk screening program. I started having mammograms in my early 30s, and to hear that, I've had callbacks several years in a row, so to hear that I've had the equivalent of sometimes 80 to 120 chest x-rays or whatever that was per year was extremely alarming. Do either of you, can you comment on this idea of x-ray exposure?
Having trained in radiation oncology and being on the faculty of radiation medicine at the Oregon Health Science University, and having done interstitial radiation implants in breasts of women who had breast cancer, I think that's unfortunate. That is way overstated. And I'm not saying it as a radiologist trying to defend, or a radiation oncologist trying to defend what I once did. No, those figures, 1 in 80 x-rays is the equivalent of 1 mammogram, or 40 x-rays. At best, it's probably 7. If you have a 2-view mammogram, that's 7 chest x-rays. But that's 1/10 of a chest CT scan. And I think the least of our problems in what was reviewed above, including pressure, I'll probably add that, the least of the problems are radiation risk and getting cancer from it, and also because of the pressure. I just don't understand how they came to that conclusion in this film, and I think it is unfortunate. I think that's the least of what you should worry about. You should worry about being overdiagnosed. You should be worrying overtreated. Yes, it's possible, and apparently 3 to 6 cases out of 40,000 each year in the UK may have become from those mammograms, but it's such a small problem. I think they overdid it.
What about, is it the same for the idea of the crushing of the breast and needle biopsies potentially spreading tumors, Dr. Wright?
Yeah, there's no evidence for that. Absolutely zero.
Furthermore, if there's a tumor big enough to be compressed, because it's palpable, or it's large enough that pressure can push it together, that's the one that needs to be diagnosed. That's the one that does need to be mammogrammed to find it, or ultrasounded and MRI, but usually mammogram with the first time, and then a needle put in it to know. Otherwise, that person with a big enough mass to be under compression to cause the problem, that's the one we would want to worry about.
I think, if we'd never cure anyone with breast cancer if we were compressing their breasts and doing biopsies and spreading their tumors. We'd never be curing anyone, but we do cure women with breast cancer. So I just think that's a complete fallacy.
Okay, and let's, one of my final questions before we turn it over will be about thermography. So there's a lot at the end of the film really pushing thermography as a safe alternative, perhaps, or some people are saying, no, it's in conjunction with the other screening methods. I'd love both of you to comment on your thoughts on thermography.
Want me to go first? So, I was a little bit surprised in the film. The woman who was the MC, I guess, was suggesting thermography for basically the entire female population as a way of early screening for breast cancer. Which seems a little much when we know that the incidence of breast cancer is a lot lower in younger women. But really, in regards to thermography, there are no randomized trials, there are no long-term trials looking at its effectiveness, and to basically just completely throw out mammography and switch to something new, I think would be a disservice to patients.
Before you comment, we think it's important to, this film is controversial and they're talking about thermography at the end as the solution. But we as an organization, we're starting to get questions from people. They ask about it. I've heard of thermography booths being set up at public health and wellness expos where someone can walk in and get diagnosed on the spot in front of like a crowd of people. Oprah has one of her doctors championing thermography, and we know the influence of Oprah. So we really think it's important that we learn more about this and sort of get your take on it.
I couldn't understand why the documentary we saw was called The Promise. And it wasn't until the last 10 minutes of almost an hour film that I realized that they were trying to say thermography must be the promise or is the promise. And I think that's unfortunate. I would say potential at best. Promise means it's really likely to happen. I don't see that. I actually, knowing from a radiation point of view and a radiologist point of view, I think it can be helpful in certain circumstances, and I'm going to mention one. But otherwise, we cannot expect it to do everything that seemed to be in the promise category until we do a lot more to understand how it works. I would not substitute thermography for mammography. But there was one woman who said, okay, I don't want a mastectomy. Can I be followed every 3 months with thermography? If the tumor is close enough to the skin to cause the skin to have a different heat or dilatation of the blood vessels so they can be picked up on the skin by thermography. After all, it only detects the heat near the surface of the skin or on the skin. That makes some sense to me. Okay, if she really doesn't want a mastectomy, I think I'd probably support her in that if it was DCIS, then follow it or do it with ultrasound or MRI. But that's the only hope I see for it right now. Documentaries are meant to be provocative.
And this one certainly was.
And I know we got to get a question, so I'm going to ask something because I think we're overstating it like the film did. I'm for mammography. I'm for surveillance at the age of 50, unless you have a reason to be evaluated sooner in life. I'm not against mammography. It definitely helps reduce deaths from breast cancer. I think it's a small percentage, smaller than we thought 10, 15, 20 years ago, before the therapy got so much better. And today is so much better that it's hard to relate to those old studies, which were done 30, 40, and 50 years ago, like the first two that were presented in this film. They're not relevant today. But I still believe some lives are really saved by mammography. And I would recommend going through the minimum number of mammograms, and that may not be what Rethink Cancer is all about, but Rethink that it also could be beneficial, not just harmful. It's a question of balance. So the US says let's do 13 mammograms. I think you have 10, and the UK is 7 on the average. Well, I think 7 to 10 makes a lot of sense. So don't leave here saying, oh, the panel said, don't go get that mammogram at 50. Hopefully by then we'll have better techniques because mammography is still pretty crude.
Rethink Breast Cancer came out as being an organization that supported our task force recommendations. I think a lot of people expected, because we're an organization that works with younger women, that we were going to be outraged that young women were not being recommended mammograms. But we think the independent panel is an important part of all of this, and so we have been supporting it. I would love to take questions from the audience for our panel. It's a little hard to see, but
Take the first
yeah, take the first hand up right here in the front.
You wait for the microphone. I know you're supposed to be on. Yeah, but they want you on the mic. Try the other mic.
Detection saves lives. Early detection saves. Oh, hi.
We're always on the same page. I was going to ask that question. It was on my sheet,
MJ,
but
okay.
I wanted someone from the audience.
Okay,
to ask.
there you go. So, not talking about necessarily DCIS, because as we've said, that's not breast cancer. Do you guys feel that early detection saves lives? Or I think one of you mentioned likely if it's something that's aggressive, then if it was non-aggressive, you could have waited another year to find it and it would likely have the same outcomes. So it's kind of a two-part question.
I'll take a quick stab at that. Yes, it does help save lives. If we're talking about breast cancer, and even to some extent PSA screening, because I am affected by that. But it's getting smaller and smaller and harder to prove that, at least for those two cancers. PSA screening is pretty much abandoned at this point, although those who've done it for all their lives, like you heard in the film, that's their career, that's what they're used to, that's what they do, can't really give it up yet. but it's getting to be less and less obvious how many lives are saved. The other point to make, and this is even a little more important, early detection, especially for breast cancer, that is detected before it requires chemotherapy, means you don't have to have chemotherapy. You can just get through with either mastectomy and hormonal therapy, or the combination of lumpectomy and radiation, and then for hormonal therapy. Not to say that those aren't problems, but maybe less surgery, less hormonal therapy. That's to be evaluated still 5 to 10 years. So early detection helps avoid some of the more intensive or prolonged, especially chemotherapy issues.
Yeah, I'd agree. I mean, I think the early screening or the screening does save lives. I think the improvement in therapies, especially the systemic therapies, improve lives. And then earlier, smaller tumors, tend to, when you do your treatment, tend to have fewer side effects. So, I mean, you can look at even axillary dissection versus sentinel node biopsy and all the complications with lymphedema. So I do think it can improve outcomes.
I guess that's what makes this just even so much harder to decide whether something is too early, that you should just watch and wait, or go ahead because the intervention is going to be less intense.
I think you'd have a hard time if it actually was biopsied as an invasive cancer. No one would buy into watch and wait that. I think the watch and wait is really with the DCIS.
Hello. I'm curious if there are other cancers that have taken the pre-cancer, whether, DCIS in this case, dysplasia, whatever the names are in other cancers, and done the research and taken, provided treatment or preventative therapies or whatever it is around that the breast cancer community is looking toward, because it seems there is a real lack of research in this particular area.
I don't treat prostate cancer, but I think prostate cancer is the example where they do active surveillance of men who have been diagnosed with prostate cancer, and they survey them over a long time period and don't treat them.
That idle, I mentioned, idle or indolent lesion of epithelial organ, that's prostate cancer too. It's also thyroid cancer, which is a good example of overdiagnosis. Thyroid cancer that is more of an epidemic of diagnosis, not of disease. And then I'll mention, because there's so many other examples of this outside of cancer, gluten sensitivity, autism, and I hope the senile dementia that I'm getting, maybe that's overdiagnosis too. So, I mean, it's not just limited to cancer. There are many other examples.
I have a question over here. Hi. So I work the front lines at Rethink and talk to a lot of young women who are diagnosed with breast cancer. And I do get calls from women who are diagnosed with DCIS. They do identify as having breast cancer. Like, they call, they're looking for support, they're looking for information and education. They're almost traumatized. I don't want to say traumatized, but they do identify as having breast cancer. What can their healthcare professionals do to help them through that process? Why are they feeling that way?
I think there's a couple of things that can be done, and we've kind of touched upon them. There was a big position paper put out about a year or two ago by Laura Esserman and group, where, number one, renaming ductal carcinoma in situ would help, because then you don't have the word cancer in the diagnosis. So hopefully that will happen on a larger, be more accepted, and will happen. And then I think secondly, it's the job of healthcare professionals and surgeons and medical and radiation oncologists to explain to patients what the difference is between invasive cancer and DCIS. Because you're right, those women do think that they've got cancer.
Let me interject that the film, a quote, that 50% of DCIS goes on to invasive cancer. Well, if I had DCIS, I wouldn't take that chance. I want to be treated. That is not correct. And the moderator of the program kept challenging, where do you get that information? So I've had a chance to spend a lot of hours trying to find it. And there are two publications both published in 2005. And there's one more, but it's very minor. The two publications, which putatively showed that of 41 women over the last 20, 30 years who refused treatment or were lost to follow-up and then discovered later and didn't get treated. So it was fortuitous that they weren't treated, and who are now sufficiently older that they can find out what happened to their cancers or their DCIS. Turns out that almost all of those patients, if not all of them, who went onto DCIS were not found at screening. They were found because they had a lump or a nipple discharge or some other pain symptom. So they're not screen detected DCIS. So mammograms that are done for screening that find DCIS have not been found yet to progress anywhere near 50%. Yes, there are some examples. Laura Esserman herself told me she's got 2 or 3 patients in her practice over 20 years of thousands of patients. It's nowhere near 50. It's probably less than 5.
I would comment on DCIS just because I see it in my surgical practice that, we do see a number of women with extensive DCIS in their breasts, like 6, 7, 8 centimeters of calcifications. No, it's screened. It's picked up on mammo, and they're often younger. It's high-grade DCIS, and when we do treat them surgically, there's a reasonably high proportion of those women, 20 to 25%, who will have microinvasive breast cancer mixed in with their DCIS on larger, 6 to 5 centimeters and more of DCIS.
And that's 1 to 2 or even 3 inches. Be surprising that that wasn't in some way felt or could have been palpated. But okay.
Dr. Wright, are you noticing a shift in more women with DCIS requesting mastectomy versus breast conserving surgery?
There is certainly trend across the U.S. that's been documented. It's not been documented in Canada, but it's been quantitatively documented in the U.S. that the request for bilateral mastectomy has increased for women with early stage, either breast cancer or DCIS. We've looked at this qualitatively, so we've interviewed surgeons in the US and in Canada, and we've interviewed patients in Canada, and all of the surgeons felt, both in Canada and the US, that request for bilateral mastectomy has increased substantially in the last 5, 6, 8 years.
Any understanding of why?
Yes, Jolene. That's one
Not
of the reasons
Angelina
why.
Jolie. Angelina Jolie is a different circumstance, right? She's a BRCA1 or 2 carrier. I can't remember
But that's
which.
lost often.
Yeah, that is lost. What we found when we interviewed patients was that a lot of this is driven by fear, which is understandable. A lot of it's driven by, I don't want to go through this again. A lot of these women have had experience with breast cancer previously, either contact with family members or with friends, and they've seen what's happened maybe 20 or 30 years ago to their mother or their sister, but the influence of family and friends is very strong.
Would it also be because our reconstructive options are improving and there's better surgical options?
It's partially due to that, but the overwhelming is fear of recurrence and fear of going through this again. Some women do bilateral for symmetry, but that's not the overwhelming part of it. The overwhelming part is fear of recurrence.
So with this increase in bilateral mastectomies, how is that affecting just the healthcare system? Are OR times being affected?
It's significant. I mean, a lumpectomy and sentinel node biopsy takes an hour and 15, 20 minutes in the OR. A bilateral mastectomy with reconstruction can take anywhere from 4.5 hours to 15 hours. So it's a substantial difference in OR time.
And more other needs afterwards too, more reconstruction,
Yeah.
revisions and the like.
Yeah, often those ladies will have...
Can I say something about fear? Because I think that really is driving much of what was in the film and answers the question about bilateral mastectomy. Breast cancer is the #1 cancer feared by women. Cancer is, in fact, the most feared disease in North America. And yet, breast cancer is one of the most highly curable cancers. It's the third most curable of the top 36 cancers in women, and that's a lot of cancers, women are susceptible to or develop. It's called misfear. So we're talking about misdiagnosis. This is called misfear. And it was recently pointed out in the New England Journal again that women think they're going to die of breast cancer when it's 10 times more likely that they'll die of heart disease. And the cardiologist who wrote this editorial cannot convince her patients that they should worry about heart disease and much less about breast cancer. It's extraordinary. You should read this editorial. She's given up trying to convince them. Data doesn't help. Facts don't work. I am so in fear of cancer, and as a woman, breast cancer. Doctor, which is the quote she cites in this editorial, you can't change my mind.
Thank you. We'll maybe post that to the Rethink website. Is there time for another question over here?
Hi there. Following up what you've just said, Dr. Blair, lung cancer since 1987 has killed more women in the United States than breast cancer, and yet I rarely hear a woman tell me that she's afraid of dying of lung cancer. I should introduce myself. I'm Cornelia Baines. I am a co-investigator. Hello, hello.
Hey, great.
We've had email correspondence, but we've never been in the same room together.
Welcome back from where? Where have you been recently?
That's right. Anyway.
Outside, the other side of the world. Welcome home.
Some of you may be aware that the Canadian study of breast screening with 90,000 participants published their results looking at 25-year follow-up of the 90,000 women who were in our trial. And given the fact that several times this afternoon, I have heard that we don't have a good grasp of how frequently cancer in situ becomes invasive, it would be useful to tell everybody that in the last month in the International Journal of Cancer, we have published the transition from in situ to invasive in over 100 women who had cancer in situ diagnosed. And this is what's happened to them 25 years after that diagnosis was made. Now, all these women received treatment. 75% of them got just a lumpectomy, and the other 25% went for mastectomy. And what we observe 25 years later is that 80% of the women never got invasive cancer, 20% did. And I thought those were useful numbers to share with you, even though I will reiterate what Dr. Blair said before, you never are satisfied with the observations from one study, but at least that is one study that did offer screening to a large number of women. And that was my, not really a question.
Not a question, a chance to share some information. Thank you.
I beg your pardon?
I said that wasn't a question, but it was a chance to share some information.
But I thought it was important to share that. I also thought I heard Dr. Blair say that the detection rate for early cancers was stable in the States. Did I hear you correctly?
In young women under 40 and even under 50, the incidence without screening, because it has been very stable. Yeah, it's those who are screened who have this tremendous increase in cancer, some of which ain't cancer.
So that was my question.
And Dr. Baines, I mean, I know she may not have asked the question, but anytime you want to listen to somebody who's an expert, Dr. Baines would be that person. Of the 20% or so who went on to develop invasive cancer, having had a history 20 years ago or many years ago, of DCIS, I would bet that many of those are new cancers that were, even though there was a DCIS diagnosis many years ago, isn't the same cancer. This is the cancer they would have developed if they didn't have DCIS years ago or because of a genetic predisposition. But it's not because it progressed, it's because it's a whole new cancer that developed so many years later.
I want to thank everyone, and I really want to thank our panelists. Because everyone give them a round of applause for their help today.
Thank you.
Rethink Breast Cancer has talked about needing a full-day symposium on screening, so that might be in the works in the future. One question I didn't ask was the confusion about percentages and absolute risk versus relative risk, but we actually have a sheet that I've pulled off of Health Canada's website that really explains it, and it's a great resource. We're going to be handing it out at the front, so I know there's a lot of confusion around percentages, and this one makes it all laid out clear so you can understand when you hear different things tossed around. So thank you again for being here today, and have a great afternoon.